Good day, everyone. I want to thank the local organizing committee for this AGM, for the opportunity to speak on this very important topic, understanding cultural diversity in palliative care. I sincerely apologize for not being able to be here with you in person. I had made all plans to be there, but certain other situations have arisen. Just know that it is not my nature to miss the AGMs of Hospice and Palliative Care Association of Nigeria. I think in the history of AGMs of HIPCAN, this is the very second one I am ever missing. I think I missed Ilorin 2009. I've forgotten which year it held. And that was because we were already preparing to go. Then we realized there was a riot on the way, and we had to turn back. This is another one where very, very stringent circumstances were responsible for me to thwarted all my plans to be there with you in Port Harcourt, but I am here with you in spirit, and I want to commend the President, Madam President of HIPCAN, and her ESCO. They have done very well, and I keep wishing us well as we go along. Let me not take so much of our time with preambles, because I know we'll always be short of time. Let me just go straight into the topic. We're talking about understanding cultural diversity in palliative care. We'll just run through a little bit of what cultural diversity really is. We'll talk about cultural competence in healthcare. We'll talk about the various cultural perspectives to illness, death, and dying, and maybe dwell a little bit about communication and cultural sensitivity, give a few practical approaches, especially to ethical issues, and then I think that should suffice for us to conclude. I'm hoping that the slides will be there with you and somebody is running through them as we go along. Now, we all know that palliative care aims to improve the quality of life of patients with serious illnesses as well as their families. It addresses the physical, emotional, social, and spiritual needs of these parties. In our increasingly diverse world, understanding and respecting cultural differences is crucial for delivering effective and compassionate care, which is palliative care. In this brief talk, we will explore what cultural diversity means, how it impacts palliative care, and practical strategies for healthcare providers to enhance their cultural competence. So, what is cultural diversity? Well, almost everybody already knows the definition of culture, which is a people's way of life, So, the variety of cultural or ethnic groups within a society make up the cultural diversity of that society. It encompasses differences in race, ethnicity, language, religion, socioeconomic status, and so much more. In healthcare, cultural diversity affects how patients perceive illness, make decisions about their care, and interact with healthcare providers. Therefore, cultural diversity is a very, very important factor when we talk about caring for patients in all spheres of sickness, because whether we like it or not, their perception of what is wrong with them, what should be done for them, falls back on their cultures, and we cannot afford to ignore this very, very significant aspect of their lives, especially the social, the psychosocial component of their care. This brings us to the concept of cultural competence, because we have to ask ourselves then, it's not just to be medically competent with regards to our administration of our drugs and other interventions, but as healthcare givers, are we actually culturally competent? So what is cultural competence? Because it must factor very well in this conversation. Now, this refers to the ability of healthcare providers to understand and respond effectively to the cultural and linguistic needs of patients. And it basically has four components. There is awareness of one's own cultural worldview, because the healthcare giver himself, the healthcare professional, is also a human being that comes from a society and has his own cultural worldview. Then there's the knowledge of different cultural practices and worldviews. That healthcare giver has to fully be aware of the fact that the world doesn't revolve around them alone. So they have to be aware of the different cultural practices and worldviews, especially of the people they are likely to encounter on a day-to-day clinical setting. Then that individual needs to also have cross-cultural skills. So another component of cultural competence is cross-cultural cultural skills, and then experiences with diverse populations. Now, these 4 factors need to come together, in a very good way for us to define a healthcare giver as culturally competent. The issue of cultural competence is a very, very big issue, especially right now in palliative care and even in general healthcare. And we could spend a lot of time talking about what a culturally competent healthcare system is. Now, this is a system that acknowledges the importance of culture. It incorporates the assessment of cross-cultural relations, recognizes cultural knowledge, and adapts its services to meet culturally unique needs. And we could talk about the 4 C's of cultural competence. There are lots of things we could say about cultural competence. The 4 C's of cultural competence: curiosity, comfort, clarity, confidence. We could talk a lot about the various models of cultural competence: the inequalities imagination model, Kian model, cultural empowerment model, crash model, various factors. Some people talk about the 7 factors of cultural competence, the 4 principles of cultural confidence, the 6 domains of cultural competence, 7 elements, 6 core elements, and all of that. So cultural competence itself is one area where, if we just decide to speak on today, we will spend the whole day and we will not even get to the bottom of it. I think what I will do is to incorporate a table that tries to relate to all of these things I have mentioned as one of the appendices of my of the slides I will send across, even if it is not in the slides themselves, so that at least it's self-explanatory. So when we take a look at it, it will give us a better idea. But I think we need to proceed further in this lecture, because I know that time would always be a factor as we move along. Yes, we have to move along. So let's talk about cultural perspectives to illness, dying, and death. Now, based on where we are talking about, cultural beliefs and practices differ significantly. And in a country like Nigeria, where we have so many ethnic groups, this is not something we can just sweep under the carpet. We have so many cultures, so many tribes, and different cultures have unique beliefs about the causes and meanings of illness. There are those that still view illness as a result of some spiritual imbalance. There are those who still view illness as a result of some kind of moral failing. Now, the attitude of these people, which is cultural, would impact significantly on how they see ill health, will impact significantly on even how, their health-seeking behavior, how willing they are to subject themselves to treatment plans that we will lay out before them, because they know, as far as they are concerned, these issues are far beyond the normal science that we can see, and they are thinking about moral issues, they are thinking about spiritual aspects. Thankfully, this is palliative care, and palliative care knows that all these other aspects of health, all these other aspects of the problems a patient can have are components that still have to be tackled by the health system, because we need to see patients from the holistic point of view, not just the physical, but the physical, the psychological, the social, and the spiritual. Now, cultural perspectives also, have some influence on the practices that various societies carry out around death and dying. They vary widely. There are various mourning rituals. There are societies that emphasize a lot of things. Women need to do certain things, bath dead bodies, shave their hair, always wear black. These things all differ based on the societies we come from. There are even differences with regards to the dying process itself. There are certain communities, certain tribes that believe that death is usually better at home. So they believe in dying at home, surrounded by loved ones and all of that. While there are other cultures that will just naturally tend to push the patient out to the hospital. So some people will be far more receptive to having hospices within their communities than others. There are so many other places that if you set up a hospice, almost everybody is going to run away from that hospice because they will view it as a place of dying and nobody will want to have anything to do with it. While it would be acceptable in some other communities because of their cultural perceptions, their perceptions about illness, about death, about dying. I don't know how many TIV people are in my audience, but I am very sure those TIV people that are knowledgeable about, there will be lots of TIV people that are knowledgeable about what I'm about to mention, the Orakombo culture. You know, it's an old thing, so we do not talk about it much anymore, but if you ask a TIV person, they will tell you that there was a time that there was even a culture among the TIVs and even the Nupe tribes from Niger State that encouraged some form of passive euthanasia. All of us know right now that euthanasia is not acceptable anywhere within the shores of Nigeria. Well, maybe because those cultures didn't have hospitals close to them then, they had so many factors, and because of certain beliefs that they had. For instance, they will tell you that somebody has taken a charm that prevents him or her from dying. So when the person is in a comatose state and is having all of those death rattles, there are signs of life, but the patient is comatose, is not dying. The general perception at that time was that this individual has taken a charm that will prevent him or her from dying. So what do? The charm is called Akombo. So they need to call an Orakombo, who is like a traditional medicine man that specializes in taking away this anti-dying charm from the dying individual. Well, there are so many interesting aspects to this where you talk about him actually sending all the members of the family away, and then alone with the dying patient gets to strangulate the patient, making the patient die, then bringing out maybe a rat or something from the bag he always carries and comes out and displays it and says, yes, I have succeeded in taking this charm out of the person, and that's why the person is dead. Lots of things, but you see, all of these spill around culture, and we need to have them in mind when we are addressing issues that have to do with death, dying, because whatsoever people do is implicitly tied to their cultural perspectives. All of these impact on care. For instance, there are cultures that emphasize family members as the major decision makers. So you have a patient that needs a particular care, probably needs surgery urgently, but that patient is waiting for his or her family members to take the decision on whether they should have that surgery or not. And while they are busy waiting, death is knocking on the door. This is against some other cultures that emphasize the patient's role in decision making. So you see, somebody would wonder whether these other cultures that talk about the family as the major decision makers in this case are not actually impinging on the patient's autonomy. But these are all the issues that we must consider, and we must be very, very well versed with the culture of the society in which we practice. Otherwise, we could do something thinking that we are running by ethics, and we end up running afoul of the cultures within the setting where we do our practice. In all of this, the role of communication is one that cannot be overemphasized. You see, effective communication is the key to providing culturally competent care. It may include using professional interpreters sometimes, rather than just relying on family members who may not be able to accurately convey the medical information we want the patient to receive. And healthcare professionals should also be aware of non-verbal communication styles. We are encouraged to use them, but we should also know that some of these non-verbal communication styles also have to relate with the culture. Let me give an example. Direct eye contact, for instance. There are certain cultures in which when you have direct eye contact with the individual you are communicating with, it helps to build trust. He sees you as confident. He sees you as trustworthy. In another setting, that direct eye contact could be looked at as disrespectful. So because this person already perceives you as being disrespectful, it already gives the person an impression that could influence how they receive whatsoever you eventually get to tell them with regards to their care. So while one culture emphasizes direct eye contact as a positive thing, it could be a negative thing in another culture. It's just like touch. Many cultures, accept that touching the patient while you are talking to them is a form of giving them some kind of comfort. It's a kind of reassurance. It makes them know that you are there for them. You are saying, I am here. I do not see you as offensive that I cannot reach out and have physical contact with. So touch, maybe touching the hand, and even for a patient that is on the bed, maybe rubbing the feet and all of that. Now, some cultures will not frown at this. But we have to be aware that there are some other cultures where this is absolutely frowned at, especially say you are a male caregiver and the person sitting in front of you or the person lying on the bed is a female patient, and then the husband comes and sees you touching her hand or rubbing her feet or something. So these are various non-verbal communication styles. They are very helpful, they are very useful, but even then we have to be careful in using them, putting at the back of our minds the cultural setting where we are practicing. So it's very, very important that we are aware of effective communication because it helps in building trust with patients and their families, and also engaging families in the care process for our patient is very important. So we find ourselves consistently communicating with the patient, communicating with the family, helping to build trust. But even as we do this communication, we must be careful because communication also has its place, and we must put at the back of our minds the cultural sensitivity. We must be culturally sensitive, to our practice setting, even while we are communicating in how we communicate with our patients and with their relatives. Otherwise, we could end up, getting a negative outcome for what we have a positive intention for. I don't know if you get what I'm trying to say. Well, so we must use communication effectively, but we must also be very careful as well how we use communication tools, especially those non-verbal communication tools, in order not to worsen the scenario that confronts us with our patients. Well, are there practical approaches and ethical considerations in all of these things that we have been discussing? Yes. Adapting care plans to cultural needs is very, very important. That is practical. You know the cultural needs, the culture of the patient you are dealing with, and then it helps you to adapt practically the care plan you are drafting for this patient. Let me give an example. It falls within dietary restrictions, religious practices, and even traditional healing methods. You must incorporate all of this in the care plan as you are planning for a patient. Let me give an example. It's like knowing, for instance, that your patient is a Muslim culturally, and then you are sitting down by the bedside, and because the patient needs a lot of protein, you are listing pork, for instance, or dog meat as some of the things the patient will eat. So these are factors that are cultural and probably religious. But when we are drafting care plans for our patients, we have to put them into consideration. Otherwise, it becomes so easy for our patient to reject our care plans and not stick to whatsoever we are, outrightly reject whatsoever plans we have for them. And this impacts eventually on the outcome of our health care. We even find ourselves sometimes facing ethical dilemmas that have cultural contexts, and ethical dilemmas could also arise in cultural contexts. Some of them arise when cultural values conflict with standard medical practices. For instance, there are some cultures that I had mentioned earlier, cultures that emphasize or prioritize collective decision making over individual autonomy. It's an ethical issue because autonomy clearly is one of the very, very key issues in medical ethics. So are we going to jettison autonomy, that is literally jettison ethics, or Are we going to offend the culture of the individual, offend the relatives because we are insisting on medical ethics being followed? So these are practical situations we could find ourselves sometimes that we would be forced to, make some decision that would be for the good of the patient. For instance, there are ethical frameworks, there are ethical decision-making frameworks that exist, and we might consider using these frameworks, especially those ones that consider the cultural values, that incorporate cultural values within them. And for instance, we could use cultural mediators. And if the worst comes to the worst, we may find sometimes situations where we might even have to refer to the hospital ethics committee to clear us out. At least let's know that legally we have a backing for whatsoever decision we eventually get to make for the good of our patient. Because you could have a very good intention, but when we stand before our regulators, the councils that regulate our practice, we need to be able to fully defend ourselves, and it might not go exactly the way we are seeing it on the practical basis of common sense. Well, I think over the past few minutes we have gleaned enough over this very important topic, at least for me to be able to conclude. So let me just say in conclusion that understanding cultural diversity in palliative care is essential for providing compassionate and effective care. And by developing cultural competence, we can better meet the needs of our patients and their families. We must keep alive discussions on this very important topic. We must keep talking about the importance of cultural diversity and exploring the various cultural perspectives on illness, death, and dying. Also, we must keep examining effective communication strategies and considering practical and ethical considerations to culturally competent care. Thank you once again, the local organizing committee. I really wish I were there to really sit down with Dr. B. I look forward seriously to seeing you, Dr. B. But well, I pray other opportunities will come along. Thank you very much for the audience. Thank you very much for the opportunity to share my thoughts with you. Have a wonderful day as we go along. Thank you very much.